Fibroadenoma. A fibroadenoma is the most common cause of a breast lump in women aged 15 to 25 years. It arises from hyperplasia of a lobule and usually grows to 2 to 3 centimeters in size. Fibroadenomas are sometimes called breast mice or a breast mouse owing to their high mobility in the breast.
Go into normal breast histology. In this histology, we can see ducts there, interlobular stroma there, acinus there, terminal duct lobular units there. So these are the major components in a breast. Here the lobules and ducts are interspersed between fibroadipose connective tissue. We all know breast is a fatty tissue, so some adipose tissues also here. It's like a rule, so kept in your mind, like if a non-lactating or a postmenopausal woman, there will be more stroma than lobules. So never forget this. It's like a rule, so never forget it. Histopathology of fibroadenoma. Here we can see the enlarged fibrous stroma. Before that we saw the normal tissue of the breast. Here we can see the enlarged fibrous stroma. Because of this enlarged fibrous stroma, what will happen is the duct will be compressed like a slit. Now we can just look into two variants. Because it is due to the risk for malignancy. There are many variants there, but due to the risk of malignancy, just we are looking two numbers. One is juvenile fibroadenoma. In juvenile fibroadenoma, here you can see the epithelial become hyperplasia. So increased epithelial hyperplasia with gynecomastoid like micropapillary projections can be seen in this variant. What about the complex fibroadenoma? Here you can see a cyst. This cyst is more than 3 mm in mm. It's seen in sclerosing adenosis, papillary apocrine metaplasia.
Recap. It is well circumscribed, unencapsulated. It is a biphasic tumor, proliferation of both glandular and stromal elements. Glandular component shows 2 recognized growth patterns. Intercanalicular, glands are compressed into linear branching structures by proliferating stroma. Pericanalicular, glands retain open lumens but are separated by expanded stroma. Glandular elements have intact myoepithelial cell layer. Variants. Juvenile fibroadenoma. Increased epithelial hyperplasia, with gynecomastoid-like micropapillary projections. Complex fibroadenoma. Cysts greater than 3 mm. Sclerosing adenosis. Papillary apocrine metaplasia. Are fibroadenomas precancerous? Yes. It can turn into malignant lesion if left untreated for a long time. Relative risk of fibroadenomas. Simple fibroadenoma 1.5 to 1.7. Juvenile fibroadenomas 3.4 to 3.7. Complex fibroadenomas 3.0 to 4.0. These particularly turn into lobar carcinoma, especially in the setting of a family history. Let's look at imaging of fibroadenoma. Mammography. This is a cranial caudal view of breast view showing popcorn calcification typically seen is postmenopausal women. In younger women, it is well circumscribed discrete oval mass hypo or isodense to the breast glandular tissue. Ultrasound. Typically seen as a well circumscribed, round to ovoid, or macrolobulated mass with generally uniform hypochogonicity. Recap. Mammography. Fibroadenomas have a spectrum of features from the well-circumscribed, discrete oval mass, hypo or isodense to the breast glandular tissue, to a mass with macrolobulation. Involuting fibroadenomas in older, typically postmenopausal patients may contain calcification, often producing the classic, coarse popcorn calcification appearance. In some cases, the whole lesion is calcified. Ultrasound. Typically seen as a well-circumscribed, round to ovoid, or macrolobulated mass with generally uniform hypochogonicity. Intralesional sonographically detectable calcification may be seen in 10% of cases. Sometimes a thin echogenic rim, pseudocapsule, may be seen sonographically. Management. Fibroadenomas can be expected to shrink naturally, so most are simply monitored. Indications for surgery. Age over 30. Suspicious features on imaging. Microlobulation. Atypia on histology. Size more than 5 cm. Family history of breast cancer. Patient's preference.